Good afternoon, everyone. It is an absolute honor and privilege to welcome you all on the occasion of the Somaiya public lecture. Today, we have gathered to hear from none other than Dr. Soumya Swaminathan, whose work has had a profound impact on global health. I request respected Dean Sir, Dr. Sameer Joshi, to kindly escort the esteemed guest to the dais. Requesting Honorable Vice Chancellor Sir, Professor V.N. Rajasekharan Pillai Sir, to join us on the dais, please. Thank you, everyone. Requesting everyone to rise for the campus prayer, please. Thank you, everyone. To officially commence the proceedings of the session, may I request Dean Sir to welcome our guest, please.
Good afternoon, everyone. Honorable Vice Chancellor, Vijayavihar University, Dr. Rajasekharan Pillai. Honorable Dr. Soumya Swaminathan, former DG ICMR and former Chief Scientist WHO. Our distinguished guests, faculties of KJSMC and KJSIT, and dear students. It is an immense pleasure and profound sense of privilege that I welcome you to this much awaited lecture on policies, global and Indian policies in epidemic prevention. Today the world is extremely interconnected and vulnerable to rapidly developing infectious diseases, and we are yet to recover from the shocks of COVID. Many of the families are yet to recover. Right now, just now, while entering, when Madam was ascending, Madam said, I am known by COVID. Okay, because she was at the helm of affairs and COVID struck, and she ably managed this scourge of humanity. Many families have been destroyed, health systems were destroyed, economies and societies were destroyed. So understanding the nuances of policy making in this particular direction is of paramount importance today. Na toham kamaye rajyam, na swargam, na punarbhavam, kamaye dukkhatattanam, praninam artinashanam. I just now recited is the motto of Somaiya Medical College and Research Center. It was established in 1991 by Padma Bhushan late Sri Karamshivai Jethabai Somaiya and nurtured by late Sri Santilalji Somaiya. And presently it is led by a team by Honorable Mr. Somaiya, our chairman. Our motto is what you receive from the society, give it back multifold. KJMCMC is not only the first choice as far as MBBS students are concerned, and definitely we are number one in Maharashtra, amongst all private and many government colleges. But it is also a good research center, an acclaimed research center. We endeavor to produce medical graduates who are competent and globally relevant, globally competitive. We are a good center, acclaimed center in hematological malignancies and rare genetic disorders like thalassemia and hemophilia. Currently, Dr. Swaminathan, a globally recognized scientist and clinician and public health expert, does not need any introduction as such. She is a leading voice of fight against infectious diseases and played a pivotal role, being DG ICMR and thereafter at WHO, to save countless lives by complex diseases which spread through the mankind. Resource limited setting working. As we still know, when at 2011 onwards till 2022, I was in charge of a clinical trial unit association with Johns Hopkins University, and Madam was our only savior. We used to, many of the times, Vidya used to say, Madam se baat karna hai, Madam se. I used to also could interact with her, and she was a savior of the research projects many of the times. So she was right from her NIRT days. She was with us. Today we have an opportunity to learn from our vast experiences to develop the resilient health systems and to prevent future epidemics. On behalf of KJ Somaiya Medical College, Vidyavihar University and KJ Somaiya IT College, I extend a warm welcome to Dr. Soumya Swaminathan. Please give her a big hand. Thank you.
Thank you, sir. I now request Honorable Vice Chancellor, sir, to felicitate our guest, please. Thank you so much, sir. I would now request Vice Chancellor, sir, to say a few words, please. Thank you.
Today is a very important day in the history of Somaiya Vidyavihar and also for the Somaiya Vidyavihar University, which is established in 2019. Dr. Soumya Swaminathan is with us, accepting our invitation to deliver a public lecture in our public lecture series. The topic she is going to speak is very relevant, and We are extremely proud to have you, Dr. Swaminathan, here because this institution, Somaiya Vidya Vihar Trust and Somaiya institutions believe in two important areas, basic health and basic education. Your proud father, Bharat Ratna Professor M. Swaminathan, used to say that if we concentrate on health and education, the rest of the things will come automatically. The society will be empowered. We have a campus known as Somaiya Vidya Vihar, just 4 kilometers away from this place. That is our first campus. A railway station is named after us. We started our education journey in 1942. First rural school, and then we entered into higher education in 1959. And now in 2019, we are a self-financed private university in the city of Mumbai. Just by chance, in the city of Mumbai, we are the only self-financed, only private university by chance in the city of Mumbai. More may come in the future. Dr. Sameer Joshi mentioned about the principles of this education, the ethos of this institution. We believe in freedom of possibilities. We believe that through education, through knowledge, only liberation is possible. And we are a multidisciplinary university: management, engineering, medicine, health science, physiotherapy, nursing, all disciplines, in addition to humanities and social sciences in a very big way. We have a School of Civilization Studies in the university. Very distinguished writers come here and sit together and bring out books. We have also a faculty of Dharma studies here, looking at 3 important areas: the Bharatiya Sanskriti, that is Indian culture, Jainism, and Buddhist studies. His Excellency Dalai Lama used to come here and give lectures. He has also instituted a chair for Buddhist studies in the university. So we are a multidisciplinary university looking at education in a very holistic way. We have also, of course, we are supported by our trust, which is looking after responsible industry care. We have the Godavari biorefineries. We have an agricultural research institute in Dharwad. We cater to the requirements of over 40,000 farmers who are cane growers in this country. We provide education. We provide education at from the pre-kindergarten to postgraduate and research. We support research in a very significant way. And this particular lecture series is one of the prominent education outreach programs intended to share scholarly insights on contemporary issues, cutting-edge research, scientific and technological innovations with the society at large. We bring eminent teachers, researchers, educationists, scientists, writers, jurists, innovators, and social workers to offer an insider's view of their own area of work to the cross-section of the society. This activity forms part of the efforts of Somaiya Group of Institutions to contribute to knowledge through thought leadership and innovative ideas to the society at large in a contextualized way. The program showcases dynamic speakers through a number of community-based talks across the range of disciplines, encouraging constructive debate on issues of regional and global relevance. The speakers share their knowledge, network with the stakeholders, entertain and inspire. As I mentioned earlier, we have been engaged in education and research for the last 80. We have celebrated the 83rd Foundation Day last year. So he could not join because of some very urgent personal thing. He could not join. He has conveyed his regards to you, madam, and definitely he will be in touch with you for maybe number of activities in the future. So we have over 2,000 teachers. We have two campuses here in the Bombay itself, and we are definitely fortunate to have you for the lecture. We are incredibly honored to have you with us today. Dr. Soumya Swaminathan, of course, she may be introduced formally, but as many of you know, is a globally recognized medical researcher and public health leader whose contributions have been pivotal in shaping health policies worldwide. Her extensive experience, particularly as the former chief scientist of World Health Organization, provides her with a unique and invaluable perspective on the critical topic she is addressing today. She is also heading the M.S. Swaminathan Research Foundation now, succeeding her father, Professor M.S. Swaminathan, Bharata Ratna Professor M.S. Swaminathan, who is the father of Green Revolution, everybody knows. And we are celebrating, the country is celebrating his 100th anniversary from August 2024 to August 2025. A lot of activities across the country are happening. Definitely, as a university which is interested in all realms of his activities, we would also be happy to be collaborating with the MSSR Foundation for celebrating the legacy of Bharata Ratna Professor M. Swaminathan. I don't want to make a speech here. The theme Dr. Joshi has already mentioned. She's going to speak about it. I am very sure that this would be a very important topic which is of great relevance to us. In fact, I read an interview in Times of India, or I think in Times of India with Dr. Swaminathan. I read an interview. Immediately after reading the interview, I just called her and invited her, why don't you come to Somaiya Vidyavihar University and give us a public lecture? She agreed, and I am personally thankful to her for accepting the invitation. And we will continue our invitations to you to visit this campus, visit our Somaiya Vidyavihar University, which is a different university altogether. And in some capacity or other, we would like you to be involved and proactively involved in our activities too. Thank you very much, and once again, a welcome to the university.
Thank you very much, sir. It is indeed a great privilege to introduce our guest for today, Dr. Soumya Swaminathan. Ma'am is a distinguished pediatrician from India and a globally acclaimed researcher in tuberculosis and HIV, has over 30 years of expertise in clinical care, research, and translating science into impactful health programs. As the inaugural chief scientist at the World Health Organization, she led the establishment of the Science Division, driving research, quality assurance of norms and standards, and advancements in digital health. During the COVID-19 pandemic, Dr. Swaminathan played a pivotal role in coordinating global scientific efforts and in the creation of COVAX, prioritizing equitable vaccine distribution to low and middle-income countries. Prior to her tenure at WHO, she served as Secretary to the Government of India for Health Research and as Director General of the Indian Council of Medical Research. In these roles, she championed the integration of science and evidence into health policy, built research capacity in Indian medical schools, and fostered South-South partnerships in health sciences. Her illustrious career also includes serving as coordinator of the UNICEF, UNDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases in Geneva. An accomplished academician, Dr. Swaminathan holds training from prestigious institutions in India, the UK, and the USA, and has authored over 450 peer-reviewed publications and book chapters. She is a fellow of the US National Academy of Medicine, the UK's Academy of Medical Sciences, and all major science academies in India. Her numerous accolades include honorary doctorates from the institutions like EPFL, Lausanne, and the London School of Hygiene and Tropical Medicine. Currently, she contributes to several national and global advisory boards and serves as an adjunct professor at Karolinska University, Sweden, and Tufts University, USA. We welcome you, Madam. Ma'am, would you like the... No. Shift it in front a little bit, ma'am, so you're comfortable.
Yeah.
Thanks.
Dear Dr. Rajshekharan Pillai, Vice Chancellor of this university, Dr. Sameer Joshi, senior faculty members, also members of the Board of Trustees from the Somaiya family, and many friends and colleagues I see in the audience, and dear students. So firstly, let me thank Dr. Pillai for giving me this opportunity. I always enjoy, actually, when I get a chance to interact with young people. And it's a pleasure to come to this university. I'm coming for the first time, and I realize this is only the Ayurvihar part of it, and there is the Vidya Vihar side, which I have not yet visited, but hope to have an opportunity. Thanks also for the kind introduction, and also the very inspiring introduction to the university, its history, its mission and vision and the motto, and the commitment really to this very broad-based education, and also very impressed to hear about the research activities that are going on, and that I think there is a desire to also expand on the research further, especially as regards medical and health research. And having been DG of ICMR and Secretary of the Health Research Department, I recognize that there is so much unfulfilled potential in India, especially through our network of medical colleges, to do relevant research for the country, because we have probably the greatest clinical material that you will get anywhere in the world. If you go to any other country to do your training, what you will miss is the breadth of clinical cases and material, and because we just have such a large population that you also get to see all kinds of problems and diseases. And so the clinical learning is very good, but what we are weak is on the documentation, the data, collecting it very in a systematic way. So research is nothing but searching for answers from the data that you collect on a day-to-day basis. You don't necessarily need fancy equipments to do research. And some of the best research comes out of places where they did not have very much, but just basic observation, understanding what people are saying, talking to them, noting it down, and then trying to correlate those things together, formulating a hypothesis, testing that hypothesis, and then trying out an intervention perhaps which is more suitable for our context, which is affordable, which is cost effective. That is what we need more of, and we have many examples in India of people like Dr. Abhay Bang, for example, Abhay and Rani Bang in Gadchiroli, who they were trained abroad, they came back, went to a remote tribal area, at that time Naxalite infested, and set up studies to look at high infant mortality. And the solution, the children were dying of septicemia, of infection, in the first few weeks after birth. And what they did was took women from the community, illiterate or in some cases maybe educated till class 5 or 6 or 7, train them to deliver antibiotic injections. There was a lot of objection from the medical community at that time and the nursing community saying, how can you train people to give injections? They are not doctors or nurses. But there were no doctors or nurses there. So how do you save the children's lives? And so that study being published in the Lancet, it then became a benchmark for care of the newborn everywhere. And the whole concept of ashas and all that, came from what they had been testing. Of course, they went on to win the Magsaysay Award. There are many such examples of high-tech but also low-tech things which can have an impact on people. For example, kangaroo mother care. I'm sure all of you are aware that this is very traditional in India. We are used to keeping babies close to the mother. But in the West, that's not the practice. So one of the interventions to reduce newborn death, especially in low birth weight babies, is kangaroo mother care, where the baby is kept next to the skin of the mother or the father or anybody in the family for the first few weeks of life. And the clinical trials, again done in India, showed that it can reduce mortality by 25%. And also it improves growth and development of the baby, it improves breastfeeding, etc., multiple benefits for the mother and the child. So very simple intervention, very cost effective, but shown through clinical trials to be effective. Another example is ORS, oral rehydration solutions. As you know, Dr. Mahalinobis was one of the people, he passed away recently, who during the cholera outbreaks in Bangladesh, I think it was maybe at the time of the war or right after that, realized that there was no way of giving IV fluids when you have hundreds and thousands of children in these camps who were getting diarrhea. And so by preparing at just a simple solution of salt, sugar, and water could show that it dramatically brought down the mortality. And that, again, I think is one of the greatest advances of the 20th century. So just in terms of saving lives, and vaccines, of course, being the other one. So the point, little bit before I get into the topic of pandemics, is that we have a lot of day-to-day health problems related to poverty, undernutrition, and poor health-seeking practices. If you go to the remote, rural, and tribal areas, even today, people have a lot of superstition and a very poor health literacy. So just improving health literacy, improving nutrition literacy, and improving healthcare seeking practices, and also making people demand for better healthcare from the government. That's the way actually that we can actually progress towards universal health coverage in our country. But we can come back to discussing that. But why universal health coverage I mentioned? It is very important for pandemic prevention and control. We cannot see pandemics in isolation. You have to see it in the context of the health system and how we live and how we deliver our health care and so on. So this is why in WHO, our DG, Dr. Tedros, he used to say that pandemic prevention or response and universal health coverage are two sides of the same coin. You cannot do one without doing the other. You cannot say, I'll be excellent in pandemic response, but I'll be very weak in universal health coverage. That cannot happen. Because one of the lessons from the pandemic was, and this has been borne out by studies, by data, that countries which had strong primary health care and that had invested in public health systems, not the richest countries, but the countries who had done that also had the best responses. Similarly, countries that put in place strong social support systems, they had the best responses in terms of minimum deaths per capita population. And the third important factor was the trust between people and trust between government and the public. Wherever it was high, it was correlated with good outcomes, better vaccination coverage, lower death rates. So again, sometimes we tend to think of things as very biomedical. As medical doctors, we think that the cure lies purely, I have a vaccine and therefore that must work. But there are many factors between having a vaccine in your hand, delivering it to the population, acceptability, being able to vaccinate enough people to create a herd immunity so that it has an impact. Those are the social and behavioral aspects of public health, which are not always considered when a certain strategy is formulated. For example, in the US, they were the first to have vaccines. They had enough vaccines. There was no shortage. They had so many different kinds of vaccines. The government was giving it free. And yet, 50% of the US population did not want to take a vaccine. And that was because of misinformation and disinformation that was spreading through social media. And that created a big challenge. And so many people, they had a very high death rate in the US. And these were all preventable deaths. Of course, the initial 1 year, there was no vaccine. So that at that time, one could not really prevent. But after that, the deaths continued to happen in 2021 and 22 because the uptake was very poor and it was clearly along political lines. So the data shows that the Republican states had much lower vaccine uptake, much higher mortality compared to the Democratic states. So that's a very sad state of affairs when your political beliefs are coming in the way of a public health response. You can have any religious belief or spiritual belief or political belief. That should be separate from a scientific response to when you know it's a virus that causes this, and this is what can prevent it, a vaccine, there should be no second thoughts about that. Questions about vaccine side effects, that's a different issue, because that you can legitimately ask questions. Any new product, the public is entitled to ask questions, and public health leaders must be able to answer and respond to those questions. So maybe to take a step back, since I experienced COVID from the vantage point of being in the WHO from day one, I remember going back from a very brief Christmas, New Year break, 4th of January 2020. And on the 31st of December, we knew that there was something going on. Or by the last week of December, there was already in social media in China reports of unusual pneumonia cases happening. And that was not really being properly reported by the authorities, but it was there in the social media. So the WHO does have a system of gathering intelligence. It's called epidemic intelligence gathering from looking at reports, social media, newspapers, thousands of, and today using artificial intelligence, you can do that very efficiently. In fact, I don't know whether our public health agencies here have started doing that, but it's something very efficient and doable. Every morning you can have the AI tool telling you what is going on in different parts of the world or parts of the country in terms of any unusual cases happening. In India also we keep having these, right? Some outbreak of diarrheal disease somewhere, some encephalitis-like illness, some few deaths which are occurred somewhere which have not yet been investigated. At the state level, how are these things handled? Do we have the capacity, the trained manpower, etc.? So 4th of January, there was a report put out by the WHO called the Disease Outbreak Notice, DAWN it's called, which tells the whole world, it goes to all the countries, the focal points for what is called the International Health Regulations. So international health regulations were formulated in 2005 as a response to the SARS-1 epidemic, to have some rules and regulations by which countries can, they are supposed to behave if there is an outbreak which has a global threat. So it lays down all the rules, and every country has to have a focal point in the Ministry of Health, and they have to report. Certain diseases are kept in that list, which are notifiable diseases. So This was created in 2005, and very recently in 2024, it was modified after the pandemic, because there were a lot of issues which had come up. So you have those global set of rules, and countries have to report, but WHO does not have the power or the authority to sort of demand the data or go to any country and start collecting data. They cannot do that. WHO depends on the countries which are called the member states. There are 194 countries which are members of the WHO. They determine, collectively they only decide these rules. So the WHO staff members, they cannot make up rules. You have to depend on this Global Health Assembly, which are made up of the ministers of health of all these 194 countries to agree. So everything is done by consensus, usually. Very rarely is a vote taken. So, so China was delaying in the sense that they were not really very transparent with what was happening. And many countries have this hesitation. I think it was not only China, but this could happen in other countries also, because no country wants to announce that it's having some bad outbreak. Because you remember, even in India, when we had plague in Surat, it had a huge economic impact on the country, because travel, trade, everything gets affected. So even though the international health regulation talks about travel and trade should not be impacted unnecessarily, it tends to happen because people panic. So there's a reason why countries are a bit hesitant. But anyway, by the 10th of January, the first 6 whole genome sequences had been publicly made available by some Chinese scientists, not by the government necessarily, but by individual scientists. Of course, they also had to face some issues later, but became public. So we knew it's a new type of coronavirus on the 10th or the 11th of January. And within 48 hours after that, we also had a PCR protocol that was developed by one of the WHO collaborating centers. So 14th of January, that PCR protocol was on the website. So all countries could start actually detecting. And India, I think, detected the first case on 30th of January, 31st January, something like that, in Kerala, a medical student who had come back from China. And in the first few weeks, obviously, there was so much of fear and panic, and nobody knows what is this new virus, what does it behave like. So again, that's one of the lessons that we need to learn, is that in the beginning, if it is a novel pathogen, you cannot predict its behavior. So you are using your prior knowledge and history to try to do things which you think would be the right things to do. So many people felt that since influenza is what is in people's mind, when you think of a pandemic, you think only of influenza, because all the previous pandemics basically have been influenza pandemics. So this was the first one, which was a coronavirus, because SARS-1 did not really become that big, thankfully. It had about 12,000 cases and something like 800 deaths, and it was contained. Why was it contained, and why was SARS-2 not contained? The answer is in the properties of the virus. SARS-1 caused severe clinical disease in people that got infected. So you developed severe symptoms, and there was a very high mortality rate also. Case fatality rate was high. But the thing is, you could easily identify the person because that person was sick. So you could isolate, you could quarantine, and that strategy worked. And within 8 months, the whole thing was contained. In the case of SARS-CoV-2, the same strategies were, of course, tried. But what was the big difference? That there was a huge amount of asymptomatic infection, or with minimal symptoms. And of course, it was airborne, and so it was not droplet, but actually aerosol and airborne. So droplet infection, like influenza was the model. That's why initially it was like wash your hands, put on a mask, maintain distance, because if it's a droplet infection, then these things can work. But if it is airborne, then it basically means that the particles are in the air for a longer period of time. So your ventilation becomes important, how long you're in that room, with the infected person, how much virus is there in that person's breath or cough. So a lot of research got done on transmission of pathogens, which had not been done earlier. And a lot of engineers got into this, and they developed models, how when you breathe or when you talk or when you sing, these particles are coming, different size particles. Earlier we used to say less than 5 micron, more than 5 micron. There's nothing like that. No hard and fast. There's a range of particle sizes. The larger particles will settle to the ground, and the smaller particles will remain suspended in the air for even up to 24 hours. So this is why a lot of case studies started coming of people getting infected in a choir, people getting infected in a restaurant, people getting infected on a ship, even though they had no direct contact with the infected person. So you have to use these observations as they come to change your policies. So in an outbreak or an epidemic or a pandemic, you cannot on day one know everything. Neither can you make the right policies on day one. You have to start with something. So it's called, like, you take the precautionary principle. Precautionary principle means you want to prevent as much infection as possible. You use your logic and your past understanding and your reasoning to say, okay, let's do these things. Some of these things may be found later. So masking, for example, is a simple thing to be done. And India was very good because in February itself, actually, Prime Minister had talked about wearing a mask. Many countries were not at all talking about wearing a mask. And wearing a mask was a very culturally very new thing for most countries, except in if you go Southeast Asia, Japan, Korea, Taiwan, you will find a lot of people wearing masks. Normally in the winter, when they're traveling on buses, trains, they'll be wearing a mask. That's a culturally acceptable for them. But in the rest of the world, it was like you stood out if you wore a mask. But India did do that. But again, there was at that time also worry that masks were running short. As you remember, we were running short of a lot of things. Personal protective equipment, masks, gloves. Suppliers were not providing, they were hoarding. There was export restrictions. Countries were, hoarding it for themselves or selling it at a very high price. So there was also the question of, okay, should you reserve it for the healthcare workers who are at higher risk and let the entire public not wear masks? So this is why WHO in the beginning did not go for universal masking. So they were also criticized. So many things WHO also got criticized for later. But there was some logic to that, and that was that healthcare workers would be left without any masks and PPEs if the general public also starts using it. Later on, we found that you could use cloth masks also, which were good, fairly effective, not as good as N95s, but not bad, better than no mask. Now, you can't do randomized trials in the middle of a pandemic. So that's the other thing, that you will have to use the evidence. So we developed in WHO something called living guidelines. All of you know guidelines, treatment guidelines or any guidelines which are based on evidences. You do a systematic review and a meta-analysis, and then you come up with the recommendations. A living guideline is something which you keep updating because it is a rapidly changing field. So every few weeks, the meta-analysis is repeated, systematic reviews are repeated, you find out any new information has come, you update your recommendations. So we did it for treatment because so many clinical trials were going on and there was so much misinformation, if you remember, about treatment, about hydroxychloroquine, about ivermectin. There were people pushing these treatments without any evidence. And people were so desperate, including governments, were so desperate that something we have to do. They were, okay, something is there, let's use it. Fine, hydroxychloroquine or ivermectin. So again, first few months, if you do it, it's okay, because you don't know, you want to try your best. But even after the evidence comes, you should not keep on doing the same thing when you know that a couple of good clinical trials have come out by then. There is data to show that these drugs are not effective. In fact, WHO, we ran the Solidarity trial because we found that most of the clinical trials being done were very small and they did not have the power to make the conclusions. So we started something called the Solidarity Trial, which actually took place in over 30 countries. It was a very interesting concept. I think India can use that kind of concept. I've been telling ICMR. It was, the whole thing was digital. And because naturally, during COVID, we cannot go from one country to another. Get all the investigators online. The training, everything is done online. There is a very simple patient information sheet and a one-page clinical information sheet with only the essential details. Don't have to fill up pages and pages and pages of questionnaires, because you can't do that in an ICU. What did we want to know? We wanted to know whether this drug X, Y, or Z reduces mortality. That's all we wanted to know, right? Because that is the public health outcome that we were interested in. So it was easy to design in the sense that it's looking only at public health outcomes. It was administered like this. Central randomization was done. And so every time somebody had a patient from Mumbai or Chennai or Addis Ababa, they would send an email, and immediately the randomization would get done. There were 4 arms initially: hydroxychloroquine, lopinavir, ritonavir, interferon. These were all drugs which people had suggested could be helpful. Then remdesivir was another drug that was added on. Later on, some more drugs were added. So it was an adaptive trial which continued for 3 years. Unfortunately, the results for all of them were mostly negative. Remdesivir had a very minor impact in a subgroup of patients, but all the others were negative. So by September of 2020, these results were already out. And by then, the UK had also come out with their trial results showing that dexamethasone actually reduced mortality significantly in patients who were severely ill or who were hospitalized and needed oxygen in that group. But even after that, if you see the treatment protocols, continued to use the ineffective drugs. Our treatment guidelines did not get updated fast enough, and doctors in India, especially in the private sector, were over-prescribing drugs, which not only increased the cost to the patient, but also resulted in things like the black fungus infection, which was unique. It was not seen in any other country. So obviously the reason for that was that in India we overused steroids. We gave high dose for too long to patients who did not need it. So I think it's a lesson that following standard treatment guidelines, that has to be culturally, every doctor needs to follow that. You cannot make up your own treatment guidelines, and somehow we are very weak in that. That's an area where we need to be stronger, because in government you have your guideline and the government doctors follow. The moment you're in a private hospital, each doctor thinks that they have their own best practice, and it's not always evidence-based. That's the thing. So I think we have to distinguish between your own experience and an evidence base, and if the two are very different, then you need to really think rationally about why you're following something which is not figuring out in the same thing in TB. You remember, we had so many studies done in Mumbai. You go to 80 practitioners and take a history, interview. They will give you 80 different regimens that they are using to treat TB patients, particularly for MDR TB. So what does that do? That only creates more drug resistance, and it creates unnecessary cost and complications for the patient. So that's a little bit of diversion, but it's important because the lessons learned from the pandemic, we need to apply it across the board. Now, how about policies and governance? India still has a very old legislation. It's the Epidemic Prevention Act of 1897, which governs our response to epidemics. So you can imagine, we have a 130-year-old act. We have not updated it. During COVID, what happened is it came under the National Disaster Management Authority. That comes under the Home Ministry. Now, they deal very well with natural disasters. They are trained and they're set up to deal with natural disasters like earthquakes and cyclones and floods and so on. And their response has tremendously improved. I think India has really done well in terms of responding to these natural these hazards which are happening. But the mentality is more of a control type of mentality, isn't it? And that's why we saw that the police were used quite a lot to implement the guideline, whatever the strategies that were being put out. Now, this may be okay initially, but again, for a biological threat, and we have to recognize that in the future, biological threats are going to be more common, not less common. Why? Many factors are there. We have a growing urbanization, we are cutting the forest, there's climate change, there is more mixing of wild and domestic animals and birds, humans. There's globalization, of course, there is air travel, so any virus from one part of the world can cross to the other side within 24 hours. So this is why it's very difficult to stop anything. Even before you know it, it's gone. And a good example is when a new variants were being described in COVID, the first reaction of countries was close the borders. So-and-so has described a new variant. And this was very clear during Omicron. Omicron was described by scientists in South Africa who had by then become so good at genomic testing and at correlating the genomic with the clinical and epidemiological. So there's no point just having genomics. Anybody can do that. You have to correlate that with the clinical and epidemiological data. Then only you can make some sense out of it. Is this a more transmissible virus? Is this a virus causing more severe disease? Just by looking at the genetics, you can't tell unless you study a group of people. So South Africa, within 2 weeks of getting this Omicron, they had already studied it. They had realized it's very transmissible. They correlated the mutations with transmissibility and they informed WHO. And within a week of that, WHO also put the committee, and there was a committee to assess all new variants, and they called it officially as a variant of concern. You remember we had variants of interest and variants of concern. Now what happened? WHO calls it variant of concern. Within few hours, US, UK, many European countries, they announce we are closing our borders to anybody coming from Southern Africa, 4 countries. Planes will stop flying, trade will stop, everything will stop. So as a result, they suffered a tremendous amount of economic impact, naturally, and a lot of human suffering also. And so the president of South Africa at that time said, how do you expect countries to be transparent with the data and to have share whatever they are finding if this is going to be the response? If you're going to shut us out and close us down, then why next time will we share anything? Better to keep quiet, you find. And the logic was also not there because WHO had said there's no need to stop travel or close the borders because the virus would have gone long ago because it took 3 weeks. And the virus is not sitting and waiting. Let me stay in South Africa for 3 weeks till they find out. No, the virus has already gone around the world. And sure enough, there were cases of Omicron everywhere. So there were a lot of illogical things that were done which should not be repeated in the future. Now, coming back, we have, so let me say that there are things which need to be done at the global level, things which need to be done at the national level. Maybe we can start with the global. I talked about the international health regulations. That has now been modified. There's also something called a pandemic treaty. So in 2022, as we were coming, towards the pandemic was getting under control, everyone said, no, we must think of a pandemic treaty so that next time this happens, we must respond better. We should not have vaccine inequity. We should not repeat the mistakes, etc., etc. Because you remember that vaccines were made in record time, but were not available to people everywhere. And the rich countries had the lion's share of the vaccines, and most of the people in Africa had to wait till end of 21 or 22 to start receiving vaccines. So obviously that is not the perfect way to do things, because if you have virus circulating in one part of the world, sooner or later it can travel to the other part of the world. So ideally, you should protect the most susceptible people everywhere. We knew that elderly people are more susceptible, healthcare workers, frontline workers. So whatever vaccine was available early in 2021 should have been distributed to all countries to protect their most, it was 5% of the population. So we had enough vaccine to do that, but that did not work out because everyone did not cooperate. So the idea of the pandemic treaty is to learn lessons and correct some of these things. Now, those negotiations are still going on. Countries have not been able to agree on some of the basic principles like equitable access, and sharing of the the products which are developed. Everybody wants sharing of data. Like I said, the South African example, the high-income countries want everyone to share the data so that they can come to know very quickly what is happening. But when it comes to sharing the vaccine or the drugs, then that enthusiasm is not there. Then they start making conditions. We can share 10%, we can do this, we can do that. So India, fortunately, is in a very good position because we're not dependent on anybody else we are dependent in the sense that, yes, the supply chains, the ingredients, components which go into making vaccines, those we get from different countries. Because hundreds of things go into making a vaccine. And so I remember that time when Serum Institute of India had run out of, they needed these very large bags in which they used to do the culture of the virus. Those were imported from the US. The US had stopped exporting. They had their own law called, I think it was called the Defense Act or something. So under that, they can stop export if they declare a national emergency. So that's what they did. So WHO had to try very hard to get Serum Institute these bags so that production could start. So like that, you are dependent. So supply chains is very important. I think India needs to look at supply chains. Where are we dependent? On which countries are we dependent? For what are we dependent? And can we make it ourselves? So if that exercise is done, then we become self-sufficient. But still, we may not become 100% in everything. So then you need to see, okay, during an emergency, where are you going to get your supplies from? Who are the reliable partners who are going to supply you? So you need this kind of, so we were talking about pandemic treaty and access, and India being in a better position because we can make our own products, and we went very quickly from having a few ICMR labs doing the testing to having thousands of labs doing the PCR, and ultimately we had the self-testing kits, the swab kits, and quite affordable, and everyone can do the test, at home. So we were able to do that. We were able to do our own clinical trials. We were able to make our own vaccines. Of course, technology came from outside. Indian companies did come up with their own technology, but the first vaccines were imported technology, right? Like the Bharat Biotech made their own vaccine, the inactivated vaccine, but Serum Institute took the license from AstraZeneca and made the viral vectored vaccine. And then Genova, another company in Pune, developed an mRNA vaccine, which is very effective. But it came later. It took time. And now they are using the mRNA platform to develop TB and dengue vaccines also. Cadila came up with a DNA vaccine, probably the only one in the world to come up with a DNA vaccine. its efficacy was little lower than the other vaccines, so it never got used. But the fact is that they did all that innovation and R&D. So Indian companies did step up to do a lot of innovation and R&D, and they can do that for other diseases also, I feel, if there's a good partnership with the government and good prioritization. So the other thing the WHO did following this, and I set it up before I left WHO, was the priority pathogens list. So the priority pathogens list is basically identifying those viral families, mostly viral, could be one or two bacterial and fungal, those viral families which are most likely to cause outbreaks and epidemics. And among those viral families, identify one virus that could be called as a prototype pathogen. And then what you do is you make a vaccine against that prototype. So let us say we talk about flaviviruses. There are many different flaviviruses that cause human disease. You don't know which one you're going to have an outbreak, but let's say you pick any one of them and create a vaccine. It could be an mRNA vaccine, it could be a viral vector vaccine. If you had an outbreak with some other type of flavivirus, you would be able to more quickly modify that vaccine. And if you've already done the animal studies, if you've already done the phase 1 clinical trial for safety, then very quickly you can move into phase 2/3. And that is how you can shorten the time. So the goal is in 100 days next time that we should have these vaccines and other products available, diagnostics also. Drugs, antiviral drug, I think we need much more research because globally we have not made a lot of progress on antivirals. If you see, we don't really have good antivirals except for disease like HIV or hepatitis. So we need much more R&D. So you should have a plan, and the government has to take the ownership of that plan. There has to be some financing because this is all at-risk work. You're asking companies to make products which may never be used. But why do you want to make them? Because that's the only way to be prepared and to be safe. So a company is not necessarily going to invest their own money into this type of R&D or risk where they don't get any returns. Company ultimately operates because they want to sell their products. So there are certain products for which government will have to put in a mechanism and funding and some support where you can create what's called a stockpile. As you know, we have, for example, smallpox. Smallpox virus, after it was eradicated, exists in 2 labs in the world, one in the US, one in Russia, under very high security. It is managed by an international group which meets at WHO and decides what do we do with these stocks. Every year they have a discussion, shall we destroy it, shall we keep it, and then it's been going on. Tomorrow if there's smallpox or there's biological warfare, what are we going to do? We don't have access to that virus, right, or the stock. The same thing happened in Mpox, actually. Mpox, nobody had really invested in Mpox vaccines, but then when it became a public health emergency, then there were some vaccines that were originally done for smallpox and they got repurposed, etc. It took time. So Mpox also became, a global problem only when it started spreading to people in the Western countries. As you remember, in 2022, it started spreading amongst the homosexual gay community in Europe and America, and suddenly everyone woke up. Mpox had been spreading in Africa for many years and continues to do so and kill people, especially young children in the DRC and also in Nigeria and a few other countries. So that is a fact of life that for the high-income countries, if the problem comes to them, only then they will take interest in the R&D. So I keep saying this for TB also. We cannot expect that others will do the research and develop a vaccine or a better diagnostic. We have to do it in India. And the government must invest in research on diseases which affect our own population. So the priority pathogens list is now published by the WHO. So what we need to do in India is we need to look at that list and say which of these is more likely or has already happened in India, where do we want to put our R&D support, and then which companies are we going to work with, which academic labs which can develop. And we can easily do it because we have the scientific capacity to do these things. Similarly, for animals, you see a lot of these infections are zoonotic infections. Ultimately, they're going to come from an animal or a bird. And that's why the concept of One Health is important now, where you look more holistically at animals, environment, and humans. And sometimes the best way to prevent human disease is to prevent it in the animals through vaccination and through other good practices, farming practices, animal husbandry practices. So right now, there is H5N1 that's spreading in the US. H5N1 is avian influenza. So every time it's detected, you know that many poultries have to be sacrificed, they are culled. But now it has spread to cows, so it's actually spreading amongst the cattle farms. And because farming in animal farming in America means very intense, close thing, and it's kind of very artificial environment for those chicken or for the animals, for the cows. They get infected easily also. So sporadic cases in humans are being described. In fact, that H5N1 strain has undergone some mutations recently. And if it undergoes subsequent mutations which can make it spread from human to human, then that may be the beginning of the next pandemic. So people who are watching influenza are quite worried that what is happening currently in the US actually is not good, and it could also trigger the next this thing. But anyway, the CDC has more or less stopped putting out any data now, so that's also very difficult to track what is happening there. So I think in India also now we have a One Health mission and a policy and a new One Health Institute that's coming up in Nagpur, and the departments of agriculture, animal husbandry, fisheries, health, and DBT, DST, they're all come together. So that's very good approach, where all the relevant ministries have come together to work on One Health research. So I think at the global level, I talked about what is needed to be done. At the national level also, similarly, we need to do, like we need to look at governance. So do we need a new Public Health Emergency Management Act to replace this very outdated Epidemic Diseases Act? That's number one. Second is we need an epidemic fund. We need somebody at a high level of government to coordinate this. And we can't wait for the next pandemic. All this has to be done prior to the next pandemic. So there should be an empowered group of secretaries or whatever, some committee that's actually making these decisions. Then we need to support the data systems that are needed. So we have data systems that are developing now, but they're still in silos, and they don't necessarily come together at the way that we want them to come together. So really strengthening our data systems management, analytics of the data. Then we need more research and development, as I talked about, on various countermeasures, so that we are able to meet this 100-day target next time. And then finally, we need to focus a lot on risk communication, community involvement, and preparedness at the level of the community. As I mentioned in the beginning, those countries which have invested in primary health care, community health workers, even during our vaccination campaign, it was our ASHAs and our ANMs that actually were the heroes. They are the ones who, in the most difficult situation, everybody else was under lockdown, they ensured that we had a very high vaccination coverage, even in remote areas. And this is why we were able to eliminate polio and so many other diseases, maternal, neonatal tetanus, and others. So we have a strong public health workforce. We need to invest in them more, pay them well, train them, mentor them, support them, so that they can do. Because ultimately, if you go to a village or a community, these are the trusted people, because they live there. They are part of the community. So the ANM or the ASHA or the Anganwadi worker telling something, the local people actually believe, because they know that this person is from our own community and she's not going to give us wrong information. They will believe the local doctors and nurses and so on. So I think we need to invest in that, and in risk communication. Risk communication is a special, it takes some skills. Everybody cannot do risk communication well. It's a science. And particularly given the fact that we have so much misinformation these days, what we call the infodemic. WHO, we had used this word infodemic. And Dr. Tedros used to say that infodemic is more dangerous than an epidemic, because it spreads faster than the virus. As you know, anything which goes on WhatsApp becomes viral, right? So within minutes, things become viral. And usually the things that become viral are the wrong things. They are not the proper advice that somebody is giving you, but some very dramatic, controversial kind of thing, that will become viral. And so how do you deal with that? Since a lot of people get their health messaging from WhatsApp, from social media today, you need to account for it. So public health experts or public health officials today have a tough time, because they need to be ahead of the game. They need to be ahead of this. For example, HMPV. HMPV became a big thing here unnecessarily, because it's nothing but another virus which causes an upper respiratory infection. I don't know how some media people picked it up and started reporting as if it was some new virus that's come from China. Then they started showing some visuals from China. Then they started creating panic. And then health officials had to jump in and start explaining. So we have, so risk communication, public health communication is a skill, it's a science, multidisciplinary science that also involves behavioral research. You're all medical students here, I presume, a lot of you. And we are not taught a lot of social science or behavioral science, right? So we communicate in a different kind of a way as doctors, and we expect the other person to understand everything and change their behavior. That's not how behavior change happens. Giving knowledge alone does not equate to behavior change. So you can, see even in your own day-to-day life, so many things you should do. Do you do all that? Or things which you know you should not do? Do you stop doing it? No. So many factors which affect how we behave. So behavior change, especially during a pandemic, is a huge undertaking. And so we need to build that capacity in our public health departments, a small group of people who have these skills, especially the behavioral skills. They can bring that into the messaging and communicate proactively to prevent panic, to give the right messages, to get people to understand what is this disease we are talking about, and so on. So I think those are the pillars under which we need to prepare ourselves, we need to act. It's the same at the national level, it could be at the state level, at the district level. It has to go down, all the way down. And of course, at the global level, it's now much more complicated because of the geopolitics. It's even more unlikely that countries will come together now to agree on some of these things, which anyway they were not agreeing. Now it's going to become more difficult. So yes. But anyway, this is historically, I suppose the world goes through phases like this. But what, as medical people, we need to keep on explaining to the public is that this is a real risk, that we cannot just go to sleep because the COVID pandemic has faded into the memory. We have to keep on preparing for new infectious disease threats. So finally, I would like to say that, the takeaway messages really are that pandemic is a recurrent event in history. So it's a matter of when, not if, the next pandemic will come. It could be next year, it could be after 25 years. Nobody can predict that, right? But like I said, the chances of a pandemic, because of human behavior, have increased. And because we are all living in these urbanized environments, infections can spread very rapidly. Ebola used to happen in a remote village in Africa. Some few people might have died. Nobody would know about it. Those people had no contact with anyone. They were deep in the forest. Today, Ebola can spread around the world because the same person has access to a city. Once they're into a city, they will infect others, and those people can. That's how the West African Ebola outbreak actually spread. So it's a very real threat. So that's number one. Second, that you need a multi-sectoral response for pandemic prevention and response. It's not any one department. The health department, yes, should take a primary role, but you need action across departments and ministries and sectors. And this is true at the national level, at the global level. And third is that a pandemic is not only just a biomedical exercise in containment. It involves a huge impact on the economy. It has an impact on people's livelihoods, many aspects. And so the decisions that are made by government has to be, again, in a way that is informed by opinion from different sources. You need ethicists, you need social scientists, you need lawyers, you need social workers, you need civil society, and you need your medical experts. And only then can you consider all the ramifications of certain decisions that need to be made. A lockdown, what does it involve? And what could be the possible implications of a lockdown? And how, if you have to do it, what is the best way of doing it by minimizing the pain and maximizing the gain, So there are difficult decisions which need to be made, no doubt. But through this type of consultation, one can actually make sure that you're trying to make the best decision given the information that you have. So I think those are the main takeaways from me. I will stop there and turn it back to the organizers. Thank you very much. Thank you.
Thank you, madam, for your inspiring and insightful talk. Okay. I would like to acknowledge Srimati Pratima Ben Thakkar for gracing the occasion. Thank you so much, ma'am, for coming.
So I have an announcement that after the vote of thanks, we will have Rashtragit. So please do not start leaving. That's one thing. And since Madam brought about the topic of black fungus, I remember those days because I have operated the largest number of cases in the world of black fungus. So there was, I just bring out to her notice the disparity. At BJ Pune, it was there. So we had the largest case series that time in India. I have the maps of India also where the case was. And I was constantly talking with KEM. How many you have operated? When they said 16, I was operating 16 in a day. So when they said we have crossed 96, so I had already crossed 500. And Narayan Janakiraman from Trichy was claiming everywhere, yes, my series, and then he was taking workshops of 250 cases. We had crossed 500 that time. And we operated total 600 and then suddenly it vanished. So it's there. For that, even Imperial College called me to give lectures and all those things. So the thing I was thinking about why this is happening, Mumbai is much more crowded than plains of Maharashtra. Because BJ was such a center where even northern Maharashtra used to come, Khandesh used to come, southern Marathwada used to come, and South Konkan also used to come. So Mumbai was not that much. So possibly the humid air of Mumbai protected the population. That's why, because Mumbai is much more crowded than Pune. So that's just a food for thought. Vote of thanks, madam, please. Yeah. Questions are announced. If you have questions, please go ahead before vote of thanks. Yeah, please. Mic hai? Yeah. Please ask there, little loudly. Yeah.
Namaste, ma'am. I'm seeking blessings from here. I'm Dr. Subhashri Suvadashni, third-year resident from Department of Community Medicine, Nair Hospital. Ma'am, I have dreamt to become a public health expert right from second year of my MBBS, seeing you and Poonam Khetrapal, ma'am. You both are my inspiration, so it's a fangirl moment for me. Ma'am, I just want to know that I have read a lot about you right from my second year of MBBS till date. So, ma'am, I want to know, like, what made you go into like this ICMR and WHO, and how did you manage the work-life balance? Because we have to do it. We are not only a scientist, not only a public health expert, but also a mother. So, ma'am, that part of the story.
Yeah, thank you. That's a very interesting question. So as I mentioned, I was always interested in research. Maybe it was something to do with my childhood and upbringing, because I grew up in a research institute, agricultural research institute in Delhi. So always with students in the house, discussing with my father about various things. So, and then lab, all that we used to keep hearing. So maybe it was that, but even through my MBBS and my MD, I knew I wanted to do research. Somehow that never left me. And I joined the ICMR, maybe it was by chance, I would say serendipity. I was looking for a good institute to work in, and I found the ICMR offered me a good environment to pursue my research interests. Of course, within the government, you have certain limitations and boundaries, but still one could do if you were really motivated. On the WHO side, actually, that was again a surprise. It was not part of the plan, and at all. I had no intention of ever going to the WHO. I had worked in TDR, which is one of the agencies under the WHO, for 2 years. That was again more on a research. The TDR does research on neglected tropical diseases. So it was Dr. Tedros who invited me to be the deputy DG. It was a surprise, and yeah, it came out of that blue, the opportunity. And then further surprise was that a position of chief scientist was created, and he asked me, would you like to shift to that position? So most people, think that Deputy Director General sounds very grand, and you should have a title and things like that. But for me, the position of a chief scientist and the opportunity to create a science division for the first time and to really give a vision to that was very, very exciting. Nobody knew there'll be a pandemic, but still, the importance of science within WHO and bringing a focus on research, on data, on evidence was very exciting to me. So I really loved that opportunity, and I was very happy. And even during COVID, there was so much of stress and strain and tension, and everybody was working round the clock. But looking back now, I feel that I was very privileged to be able to serve the world at a time like that, in a position like that. And I think science came to the forefront during pandemic, much more than it was, before. On the work-life balance, yeah, I think that's something everyone really, especially for women,
Yes.
it is something we have to deal with. You need to, if you have a supportive partner, it makes a big difference, and a supportive family, of course. And there's a lot of work to be done in India still to bring that gender balance when it comes to house responsibilities, child responsibilities, elder care. Always falls on the woman of the house. I hope that's changing with the next generation. But also policies can make a difference. So again, it's happening, but slow. So I've been advocating that. Of course, now we have maternity leave if you're in government. Childcare. Yeah, childcare is one of the critical things which is still a big gap in India. In Western countries, you have a creche, a good high quality creche where you can leave your child safely, know that the child will be well looked after, and you can pick up the child in the evening. Here we don't have creches, either in the private or the public sector. The Balwadis take children only above the age of 3 years, and so do most nursery schools. So I feel that's a very big gap which needs to be addressed, really. Similarly, elderly care is going to be another one. We're an aging population, though we say we have a big demographic advantage today. In 10 years, that's going to change. There are more and more people living longer. they're going to need care. So both child care and elderly care is something we need to be investing in. From my perspective, I always prioritized also family. It was never one at the exclusion of the other. So the message I want to give is you can have a balance and do both. If people tell you otherwise, don't believe them. Because a lot of people will say, choose, you can't do both. You can. And you can be good at both.
Ma'am, and WHO, ma'am, just once more. Ma'am, WHO is usually like a traveling job now. So at that time, how you managed with?
Yeah, no travel, no. Everything became online.
Okay.
Yeah.
Achha. Thank you, ma'am. Thank you so much.
Thank you very much for illuminating lecture.
Would you like the mics?
Ma'am,
Just one question. Thank you very much for this very enlightening discourse. And just one small but brief question. During the pandemic, we had a visible situation where globally there was a vulnerability at the primary health care. And in today's context, when we talk about reforms based on the experiences, then looking at the epidemic vulnerability and the healthcare or the primary response to the epidemic, how do we look at the reforms that could be brought in at the Indian level? Because we have diverse population and in large numbers. Thank you.
Yeah, so this comes back to the question of universal health coverage and primary health care. I think we are on the right track because we have the Ayushman Bharat program and we are developing both infrastructure, so the health and wellness centers or the Ayushman Arogya Mandir as they are called now. We are also, so big push on infrastructure development, supply chains. I think human resources we still need to invest further because it's not just doctors you need different levels of healthcare providers. So now we have these CHOs or mid-level health providers in the health and wellness centers. That's very good move. And we need to now ensure that comprehensive primary health care can be delivered. Telemedicine also came up during COVID in a big way. That's still being used. We can work on that as well. So we need a good multiple levels of care, starting from community, health and wellness centers, primary, and then you come to your CHCs and district hospitals. The thing is that doctors are not willing to go and work in rural areas. That's a very big challenge. So though we are training more and more doctors, not everyone wants to go and work in a PHC or a CHC. So that's where we can both use technology, but also these mid-level health providers to fill those gaps. I think our data, we need to work on a little bit more because we need localized data coming and localized action based on that data because in India is so diverse and heterogeneous. Even within a state, you have so much of diversity between districts or even sub-districts. So I was in Koraput district of Orissa. I just came from there last night. And still, when you go there, you feel you're going 50 years back into those tribal hamlets, the way that people are still living and surviving on the bare minimum, you know. There's also very poor health literacy there. The practices are still, you know, not really, we would not call them the right health practices. So you have to create that community literacy demand, and this is why you need community-based health workers. So countries like Thailand have done very well. I think the Thailand model is an excellent model to follow. The last thing I would say is a focus on prevention and health promotion. We talk, of course, about yoga and about a healthy lifestyle, but we need to identify what are the major risk factors for health today, which people, some of them are personal habits, you know, smoking, alcohol, diet, certain things you ask the person to change, certain things you can't, air pollution. The individual cannot do much about it. Government has to come in. So there are a lot of environmental risks to health today in terms of air and water pollution, lead, contaminations, pesticides, chemicals. These are things where we have limited data and how it's affecting us. But the data that is coming shows that it's actually having quite a big impact on our health. So I think more focus on that and finding scientific solutions to those issues is going to be important.
Good evening, ma'am. It's always our privilege to be listening to you. So, ma'am, my two comments and two, of course, I want to listen more from you. One is about the universal health coverage. Most of the national programs and the NUHM, it has been tailor-made for the rural areas. Though we all know that the urban health, should have a different focus. We do listen to this urban health focus, but still, if you look deeply into the programs, how it is designed, they fit everything into the same, PIPs, or it's a standard PIP which has been applied to the entire urban as well as urban. So when is it going to change, or maybe we should look forward to it in some sooner times? The second point is about the pandemic. As we all know, madam, you also mentioned about the strategies. In the early days of the pandemic or any outbreak, we test everybody. But as we go further, maybe 6 months or 1 year down the line, we stop doing those tests to everybody, right? But it happened the other way. What guidelines and what things came from the departments or from the ministry was you test everybody, and there was so much of force on PCR test. Looking at the limited resources, why was that? Or probably, I know it must be some decisions which was happening there. So it becomes very difficult to implement at the field level. So I think these are the 2-3 things where we need to dwell more, and we need to develop a cadre of public health professionals who actually deal with the issues. Academic is one thing, but working in the population, working with the risk communications professionals, PROs, media, we need to develop the capacity of the students and the medical professionals to deal with the public health issues. I would like to listen more on those aspects if something is happening at the national level. Thank you, ma'am.
Thank you, and you raised some very important issues. Obviously, I can't answer all of them, but I think you partially answered yourself that having a public health cadre, that was in the National Health Policy of 2017, that every state must develop a public health cadre. Medical doctors are trained to look after individual patients. The public health thinking and public health hat is very different. So some of the decisions, like you're saying, were not appropriate, maybe because the person making those decisions was using their own wisdom. So a specialist who sits in AIIMS Delhi may not know what is the reality in a primary health center in rural Maharashtra. So they will be thinking their setting and making the guideline. So this is why guideline making, also you can have some national level guidance, but then it has to be tailored. I think health is a state subject in India, and every state can consult with their own district people and tailor the guideline. Of course, principles should be followed, which are set down by the country, but too much of centralization which happened during the COVID, I think was not probably the right approach for our country. That's one of the learnings. Urban health, I think we have to keep discussing how to go about, yeah.
I would now request Professor and Head of Department of Pharmacology, Dr. Usha Nayak, to deliver the vote of thanks, please.
Many of my questions were answered, but I have one point. Because we have the ASHA workers in this country, accredited social health activists. There was a study in one of the states, up to the state which I am coming from, Kerala. The contribution of the ASHA workers, large number of women, accredited social health activists, they're phenomenal in the in that particular state. It could be true for many other states also. What is your take on the overall training capacity of the country in public health professionals? How education institutions like this should concentrate on policies in devising the training of public health professionals dealing with the maybe barefoot doctors or something like that. What is your take on that?
So my own observation is that you need ongoing mentoring for these people. They go through, of course, initial training, but that is a limited amount of training, and then they go in the field, and then their experiences actually may be very different from what they've been trained. So now I think there is a program, I don't know if Maharashtra is doing that for the mentoring of the mid-level health providers, the CHOs. I know CMC Vellore, for example, is doing that for a few states. And that's, I think, the way to go. Because these people are, they're very committed. They are there, they are present. But they're given a crash course, and they can't expect them to handle all the complexities which they're going to see day to day. Over a period of time, their skills have to be improved through this mentoring. And today you can have a hybrid, you can do some online and some in person. So I think a few universities must be identified to do that kind of mentorship over a period of time. I think I saw 2 hands over there from students. So very last 2 questions maybe. You can...
Actually, ma'am is...
and then I also have to leave, so yeah. So.
There is Mumbai traffic waiting for you.
Yes. So we'll take 1 or 2 questions from students and then finish. Yes.
Good evening, ma'am. Ma'am, based on your talk, you had talked about that in the future the countries have a lot of disagreements. So war is inevitable among these countries. So what is your take on preventive strategies for epidemics in such countries where their entire infrastructure, medical infrastructure is collapsed? So how would you prevent epidemics of re-emerging or newly emerging diseases?
You cannot. That's a simple answer. If a country is being destroyed by war, that's not their priority really. And that's where the new infections will arise. Or old infections could also re-emerge, like polio in Gaza. There's a real threat that polio will come back. And why is it polio in Afghanistan and Pakistan, It's in the conflict areas where infections will survive. So there is no way to prevent it. You need peace. Peace and health go together. If you don't have peace, then I don't think you can have good health. Okay, last one, please. Yes, over there. Yeah.
Hello. You mentioned that you have always had an interest in research. I wanted to ask as to how did you hone your skills in research? Because as a PG resident, what I have found is that in the first year, we are asked to work on our thesis, at least the protocols that we are asked to formulate. So it is a good process. You have so many things new to you, you enjoy it. But then when you actually come to the second year and you're working on your thesis and you realize, okay, I maybe like this topic also, I would like to do something in that field. And that is when you come up with roadblocks. Okay, how am I going to work this out, or how am I going to work that out, is something that I am currently facing in my second year. So what would your advice be to budding research enthusiasts in this audience, ma'am? Thank you.
Yeah, no, that's a very good question. And I think there are many more resources available now than there were in the past. And again, thanks to the internet and online, you have a lot of resources. So ICMR runs a lot of courses. You can take them online and offline on research methodology, on ethics, good clinical practices. You can take courses in epidemiology, in statistics. So I would say that all students in their first year should start taking these courses. Some of them may be provided for you in the university, and but a lot of them could be online. And then, of course, you need to identify mentors amongst your own faculty with whom you can have a discussion. And I was talking earlier to Dr. Joshi and how more research needs to be encouraged and promoted, here and in many other medical colleges. But I would say that there are a lot of resources available now. You should look for them and take these courses and read scientific papers in the literature and try to analyze and see the methodology. So in the morning I was at the Tata Memorial Hospital, and Dr. Pramesh runs a program called Credo. He's been running it for many years now. I've been very impressed with that, because he brings people together for a week with experienced statisticians and clinical trialists, and it's mainly focused around clinical trials, of course. And by the end of the week, everyone has a protocol and they know how to design and how to ask the right questions and so on. So look for those kind of opportunities and enroll in those courses. Well worth your time. Thank you. I think.
Thank you, ma'am. Thank you so much, ma'am.
So, well, all good things come to an end, but not without impacting and inspiring all of those who are witness to it. Ma'am, I feel very privileged to deliver the vote of thanks on behalf of Somaiya Ayurvihar. We express our sincerest gratitude to Dr. Swaminathan ma'am for graciously accepting our invitation and sharing her very vast wisdom and vision on an issue of immense topical significance. Sincere thanks to Vice Chancellor sir for his support. Our gratitude to Dean Sir Dr. Samit Joshi for his guidance. We also thank the respected heads of the various Somaiya institutions and esteemed deans and faculty members of other institutions for their presence today. Our gratitude to Dr. Vivek Sunarpad sir for the venue. Many thanks to the team from Somaiya Vidyavihar for facilitating the logistics today. And all please do join us for a cup of tea. Thank you very much.
I request everyone to rise for the national anthem, please.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Tea will be there in the cafeteria area just beyond the coffee house in ground floor.